Good morning. It is Thursday, December 2nd, and welcome to the Morning Medical Update. Thank you for joining us today on Facebook and on YouTube. The Omicron variant is now confirmed in the U.S. The California case is an individual who traveled from South Africa on November 22nd and then tested positive on the 29th. Dr. Anthony Fauci says that person is in quarantine, and those close to that person have so far tested negative for COVID. That person was fully vaccinated and experienced mild symptoms, but the World Health Organization still saying that Omicron is a variant of concern. And here to talk more about that and why that is Chief Medical Officer Dr. Steve Stites. So I'm going to get with you here in just a moment. I know you got lots to say, but Dr. Damian Stevens is also here. We're going to be talking about sleep today, the kind you get, the kind you don't get. How much do you really need? And who are these people who say they only need 4 hours of sleep? And is that true? And does COVID cause people to be more susceptible? So we're going to talk all about that and how it's disrupted our lives. And imagine if you relied on technology to help you sleep at night. Now that machine is on the recall list. So we're going to dive into all things sleep this morning here in just a moment. So be sure to get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to those right there on your screen. But first, Dr. Hawkinson's off today. Good for him. But we've got Dr. Matt Shoemaker with us. He's infectious diseases. And how are the numbers looking? Good morning to you, and love the bow tie, by the way.
Thanks, Jess. Appreciate it. Today for the numbers, we have 27 active cases, 7 in the ICU, 5 on ventilators, and 14 recovering.
All right. Thank you for that, Dr. Stites. What do you make of the numbers?
Well, first of all, we don't have Hawk, but we have Shoe. I think that's the
no
one,
Hawk,
right?
but we got
Doc
Shoe. I like it.
Right.
And we got to come up with a good name for you.
Yeah, well, if he's going to wear a bow tie, he is vulnerable to all sorts of stuff.
Absolutely.
I think it's going to be now Doc Shoe. Even
I'm ready.
Brace yourself.
He is the tiger. There are a number of us around here who are Tiger Hawks. I say cheer for both now. But anyway. Okay, so I want to show you a few graphs. Yesterday, a question was asked to us about Kansas, and we didn't have all the exact answers. I found it while we were here, so can we just look at that data, guys? Thank you. So this is just a vaccination rate here in Kansas. I wanted to be clear, we all talked about that. 66% of people have had at least one dose, 55% have been fully vaccinated. You know, that's better than we sort of made reference to on the program recently, so that's good. 12 and over, 77% have at least had one vaccine. 65% are fully vaccinated, and over 65, 99% have had at least one dose, and 87% are fully vaccinated. So if we look at this next graph, this is where we also talk about the hotspot graph a lot. Mm-hmm. This says where are the hotspots in Kansas, and you can see out west, marching east, and then another hotspot down there in southeastern Kansas. But that map a few weeks ago was just more kind of a light yellow and orange. Now we're seeing a lot of the dark purple. And then what we do is you look at this map about where is the virus, where are the rates per capita increasing against the vaccination rate. So let's look at that graph. And unfortunately, Kansas turns a whole lot of purple. And you can see the little bit of red around Douglas County, Wyandotte, Johnson County, and then kind of our area around Wichita and a few other zones where there is a lot more vaccination, which is great. But a lot of purple zones, a lot of areas around Kansas, a lot of counties where there still are higher risk levels. So I think we have to be a little nervous about that, especially around Omicron. Let's talk about Omicron for just a moment. That should be the last graph, but. You know, we've talked before on this program about the New England Journal of Medicine has a podcast open to the public. This week, they interviewed one of the South African ministry professionals who is also a world-leading researcher, HIV, public health. He's also on the editorial board of the New England Journal of Medicine. And so they spoke with him, and it was a wonderful interview. If you do anything else today, and you want to know more about COVID, sit down and listen to that interview, because he does a wonderful job of talking about how we are really all in this together. And, you know, our initial response has been, pardon me.
I was going to say,
dry air.
It's okay.
He does a great job of talking about how the travel restrictions, the travel bans, you have to stop and ask yourself, is that really the right thing to do? Because once you get Omicron, once you get the population, once you start to spread it, it's everywhere now, right? Mm-hmm. It's not just going to be in one spot or one area or one city like San Francisco and here in the U.S. Rather, what happens when you close borders, you can close the exchange of information. South Africa was completely transparent about the spread of Omicron and about the sharing the genomic analysis with the world, which gives us all a tremendous head start. and yet they feel punished. And you have to say, well, what do closing the borders do when it's already everywhere? So what good does it do? And I'm not sure it really does do a lot of good. Second point to be made, South Africa has an amazing infrastructure because of HIV for public health. So they have all this information. And what they know are a couple things. First of all, about 70% of their population in South Africa has already had some form of SARS-CoV-2 and COVID-19. So they have a population that has been largely infected. Second thing, they are able to trace reinfection. You've been infected once, and you get reinfected a second time, then they check and see how are you doing. They closely monitor that. What they know is that thus far, those people who are getting reinfected with any of the variants tend to do better the second time around. And early, that appears to be true with Omicron. Now, that doesn't mean we should run out and get infected, because the reality is, as he points out, vaccination is an even better way to achieve that, but we've got to get everybody vaccinated across the world.
So can I ask you a question? And Dr. Shoemaker, jump in here on this as well when you talk about the borders. I have a feeling people are going to ask that question because I think that's the go-to. Close the borders.
Close the borders.
That will keep
We'll
less
stop the spread.
out.
And
but
the
tell
problem
us
is it can
why
stop-
that won't matter.
Well, because the virus doesn't necessarily spread like that, right? You've already spread. By the time you close the border, it's out. And so adding a few more people to it isn't what's going to do it.
It's not going to matter.
Right.
Okay.
If one person infects 8 others, or whatever the number is with the Omicron variant as it was with the Delta variant, then remember that once you've got the infection in a population, by the time you say, I'm going to close the border, it's already there.
So once it's out,
So
it's
what
out.
do you, what are you doing?
This is very different than something like Ebola that has a very short incubation period and patients' symptoms are horribly severe and you can identify them early on. People have symptoms that can be confused for allergic rhinitis or a common cold, and that's one of the problems that we face in the treatment of this is they're presenting so late after they develop symptoms, and sometimes it's too late to initiate effective treatments.
So asymptomatic hurts it.
Yeah, and I think the other take-home message is, again, we don't know enough yet, but there is reason to hope. I think Dr. Hawkinson sent me a note this morning saying, gosh, he had listened to the TWIV guy, Dr. Aracanelli, and This Week in Virology, and they were talking about how there's enough preserved regions in one of the epitopes that the vaccines cause a response to believe that people will still do well with vaccination, even against Omicron Chu. And I think, what are your thoughts about that, about the efficacy of vaccine with Omicron so far?
At this point early on, we still think it's going to be effective. We think there were enough preserved regions with the spike proteins that it should be effective. It may be less effective against Omicron than it was against Delta or the Alpha variants, but we do still think it will retain some of its effectiveness. And it's still the best way to prevent infection and definitely hospitalization and death.
And also, it helps induce T-cell immunity, which we know is not going to necessarily be affected by the variations. Can you talk a little bit about the difference between B and T-cell immunity around that?
Oh, okay. So that's a so you know you.
What does that mean?
He doesn't know about me. Curveballs are part of the deal. And
no
actually, it's
pressure.
more of a knuckleball because it just moves everywhere.
Well, I mean, it does bring up a good point because we talk to providers all the time about checking antibody levels and how we'll look at an antibody level to the spike protein, but we take it with a grain of salt because we don't know what the T-cell response is going to be. And your T-cells are your cells that are going to have the memory, and then when they get exposed to that virus, they're going to then be able to attack it. And some people have robust T-cell responses in spite of low antibody levels. So, we think that with the T-cell memory, the vaccines still may be beneficial. Now, that's if you have good B cell and T cell levels. So if you're a cancer patient on chemotherapy, you have leukemia, you have HIV, those things are different because you don't have those memory cells.
Dr. Stevens, do you have anything to add before we start talking sleep with you?
No, like Matt said, the thing that we do have is the vaccine. So why would we not use one of the tools we have?
And I remember our numbers they've come up to 27.
Yeah.
They're flat right now. We hope maybe they'll dip back down. We're pretty nervous though because we're watching mask mandates kind of dissipate from schools and other places. And so I think what we have to remember is even as we try and talk about Omicron and all that, the rules of infection control, what do they do, Jess? They keep you safe
and
wherever you go.
Wherever
you go. Yeah.
Okay, do we have any reporters on the line? Okay, so get your questions sent in to us today. We're going to get to Dr. Damian Stevens, critical care medicine, pulmonology, sleep medicine, He's kind of an expert in all sorts of good stuff. So
Well,
we're so glad.
don't give him too much credit.
Yeah,
Well,
not too
I know. It's what
I've known
that's
for a
my
long
job. I
time.
got to give you guys all the credit. Okay, so just start us out with, in this last, 20, 21 months, how much has COVID affected people's sleep patterns just overall?
Basically, you can summarize it in one sentence. There's nothing good that happens with sleep when it relates to COVID. Now, a big part of this is not a direct effect of COVID necessarily. There's so much anxiety, now we see more mental health issues and other stuff, and that's actually one of the diagnostic criteria for depression itself is insomnia. Either patients kind of present in two ways. They either sleep more or they sleep less, but the by and far and away is they sleep less. They are complaining of not being able to fall asleep, stay asleep, waking up at 2, 3 in the morning, can't go back to sleep. So, and it's not necessarily just this pandemic. Anytime you see a major, trauma in any situation like this, there's basically a pandemic of insomnia. Some will call it COVID insomnia. Some have called it coronasomnia. The one and only population that we did see, I saw a paper about a year ago that the adolescent, because the school was closed, so they didn't have to get up at 6:30 to get to school by 7:30. Guess what? That was the only population that had any benefit at all related to the whole pandemic, quarantine, shutdown, was those that could sleep as long as they wanted to sleep. But by far and away, the big thing is you see so much more sleep complaints. There was a paper out of China that 15%, they actually had some literature kind of before this, literally they were doing a study before 15% were complaining. It went up to 25% after the pandemic, during the pandemic, just complaints, sleep complaints in general.
So some complaints over the pandemic, but you're saying this was all,
The
our
whole new
lifestyle
game.
has been so different over
yeah.
the last couple of decades, and sleep patterns have got to
Yeah.
have been interrupted way far before COVID, right?
Yes, absolutely.
So what are long-term health effects for people who don't sleep right, don't sleep well, don't get help when they have sleep issues? What can that cause?
There's a huge range of issues. There's, like I said, can this insomnia bad enough actually lead to depression, worsening of anxiety, just mental health in general is one of the issues. You see patients fighting more with family members, fighting more with coworkers, just not feeling well during the daytime. Long-term chronic sleep deprivation clearly has, some issues, but that's more whenever we kind of artificially do that in the sleep lab. There's even studies looking at depriving patients of sleep and doing vaccinations. And guess what? Your immune response is not the same if you've been submitted to sleep deprivation prior to vaccination. They do other tests, look at immune response in the setting of sleep deprivation. Now, does that actually occur when it's more of insomnia where the patient is just not sleeping well versus this is kind of artificially sleep deprivation? So we don't know a lot of this. What are other health consequences? The main thing we know is, like I already mentioned, kind of the mental health consequences of this.
Mental health consequences. Okay, I have to go around the room. Dr. Shoemaker, how many hours of sleep do you usually do you need to function really well?
I like a good 8 hours.
You're a good 8 hour. You seem like are you one of those
I bet
weird,
he's
I only
one of
need
those
4
short,
hour?
kind of.
Yeah, I may not be a 4-hour guy, but I'm probably a 5 to 6.5 hour guy.
And you feel solid all day with that?
Well, to be fair, full disclosure, I have pretty severe sleep apnea.
Okay.
And this guy's my doctor, so I can make fun of him.
Okay.
He does a great job. And I went on Cpap about 10 or 12 years ago, I think.
It's been at least 10 years.
Yeah, and in fact, I finally got a new Cpap machine after 10 years. We'll be talking about that, but CPAP has made all the difference. I sleep far better on those 6 hours or 7 hours or 6.5 hours or 5 hours than I did before when I didn't have it. And so I
it was the
feel
quality
great.
of sleep you're
Yeah,
getting.
really. Like last night I went to bed at 11:30. I got up at 11:40 and I got up about 5:45 this morning because I worked out. And then I come to work and I'm acting crazy. But I'll tell you, the getting healthy sleep, it's not just about how much you sleep. It's really about the quality of your sleep that is really restorative. Like I feel great today, but I started with my CPAP on right at the beginning last night and I slept all the way through. It's fantastic.
Just like Dr. Stites mentioned, it's not just your quantity, it's the quality also is a very, very important point.
So how many hours of sleep do you get, and how do you make sure it's quality?
Between 6 and 7.
Okay.
You just try to avoid, the electronics late at night, anything, a quiet sleep environment. This whole thing about, trying to keep the same bedtime, same wake-up time, all those things. What I've told a lot of my patients that have this anxiety, this worry about, several patients truly would meet criteria for PTSD. You've lost a job, right? You've lost a family member. Several of my patients lost family members. So then it's almost a PTSD experience on top of all this other stress of the economy, employment, family. Studies have early shown that once you start depriving people of sleep, less than around that 6 to 5 hour window, you start seeing these really severe decrements in function. They have kind of this, they call it a PVT test. It's basically like a video game. You can do other kind of neuropsych testing. And the vast majority of people, once you start getting less than around that 6-5 hour kind of window, but it's this huge, like everything in biology, there's this huge bell curve, as we say. You kind of have, that's where you start seeing this decrement. And there are a handful of patients, they've done some genetic studies, a group in California has done this, and they've kind of found these clusters of families where everyone in the family sleeps 4 to 5 hours, and they still seem to be fairly normal. But we think that's may reflect a genetic variant, because when you look at the population as a whole, because on the other end of that spectrum, I have patients, unless they're getting that 9 hours, they just don't feel like they can function. So there is this kind of variability, and by and large, most patients can tell when they are at that point or what they truly need. Sometimes they may, that's why we see them in clinic and discuss that. But by and large, patients can kind of tell their threshold from whenever they just aren't going to feel right.
So in a severe case, could sleep deprivation cause like long-term damage or something really bad to happen?
Like I said, there's studies. Most of this data, most of this research has been done in animals. And yes, you can truly, one of the models is they will put a mouse or rat on a floating device, and they truly can't fall asleep, because if they fall asleep, they fall into the water. And you can sleep deprive a mammal to the severity of they will have cardiovascular collapse.
That's what I was going to ask, how it affects the heart.
Yeah, that's basically how that occurs. It's everything from the sympathetic, or the adrenaline system, as we call it, surge, and all these other effects. But that's a severe kind of setting. We don't really see that in humans, because what happens to the human body if you sleep deprived long enough, you're just going to sleep. But we just do think there's this long-term consequence. We don't really know the biology, the physiology, how that leads to that. Long-term also, there's even some studies that show that shift workers, and the most common thing in shift workers is they end up sleep deprived if you do that long enough. And there's even some literature in shift workers that they may not live as long. But is that related to the factor of shift worker or some other issue? We just don't know for sure.
I used to get up at 2 a.m. every day when I anchored morning news, and I would split my sleep in half. I would do, I'd probably sleep 4 hours. There were some nights I would get 1 hour of sleep, and then I would get sleep another 3 or 4 hours. And I hope that doesn't mean bad news for me.
But like I said, we still, and I don't want to say this to, scare patients or, individuals listening, because, the body as a whole knows, by and large, knows that it needs to sleep. And it's not probably this acute effect. It's more the long-term, try to get the sleep that your body needs for its function.
That's one of the reasons I got out of that crazy schedule, because I thought this has to be causing some problems.
But the lack of sleep is a public health crisis, and we're talking about COVID all the time, but there is a public health crisis around sleep in the U.S. And you look at the amount of caffeine that is being consumed in the United States per capita, it's extraordinarily high. And some driver of that, I think, is a lack of sleep, because our lifestyle is so geared to go, and to our little devices, our external brains. But and then with the obesity epidemic on top of that, there's a lot of sleep apnea, which is sleep deprivation, and so it leads to a lot of health issues. So it really, we talked about it for a long back in the 90s in truck drivers, right?
That's kind of where it first began.
Let's talk a little bit how that kind of stuff came about.
Well, that actually was directly related to the risk of driving while sleepy. And there were several lawsuits related to truck drivers having an accident at 2, 3 in the morning, or sometimes even just during the daytime. It was the fact they had apnea untreated. It was the fact they may be driving and sleeping 4 hours a night for several nights. So several states legislated sleep times. You had to have your logs while you're a driver. You'd have to be evaluated by the DOT, as we call it, Department of Transportation, certified individual. They finally started screening for apnea. They would require compliance downloads on Cpap to make sure that the individual driving was following the guidelines. So that's actually become much, much better, and there's a greater awareness within the sleep community, within the occupational medicine field regarding that issue.
Okay, I want to talk about one of your patients, Dr. Steve Stites, and tell us about sleep apnea. What is it, so people understand it? And I want to hear a little bit more about what it's been like for you.
Obstructive sleep apnea is simply lack of breathing at night. Now, There's a couple different manifestations. Almost 90% of patients with obstructive sleep apnea will snore. Apnea, by definition, of 10 seconds of no airflow. We also count in what we call hypopneas, and when you hear the word hypopnea, it simply means a shallow breath. So we basically combine shallow breaths and no airflow together, and then we divide that by how many hours of sleep, and that's this index, as you'll quite often will hear. Many patients will be aware of their index, and we count how many times an hour, and based on that criteria of mild, moderate, and severe, we also look at how low the oxygen drops, how fragmented their sleep is, and that's what obstructive sleep apnea is. The strongest risk factor is being overweight, but about 20% of patients with obstructive sleep apnea still have a normal BMI, as we say. And that's related to probably facial anatomy, airway structure. That's a lot of times when you hear these, grandfather, father, everyone in the family snores like crazy. Maybe a couple are overweight, but the rest are actually a completely normal BMI, and yet they still snore and have the apnea. And that's kind of the biology, neurophysiology, and the airway structure, anatomy that we think those patients have the sleep apnea.
But just because you snore does not mean...
And about 50% of patients that snore have apnea.
Okay.
So
when do you know if you need to get it? Because I've recently learned that I snore. I did not know I did this, and I didn't know. So how do you know to get in?
The only way you can ever be for sure is to have a sleep study.
Okay.
A couple other signs, if it's more than just snoring, is kind of what I mentioned. If they're snoring and there's actually pauses in breathing. The accuracy of a bed partner is kind of mixed. That's, it's better than this having no history of a bed partner at all. Like, do you truly have apnea where you're not moving air? Quite often you hear the choking, the gasping. Sometimes a patient themselves will wake up gasping. When you hear that, that's a higher suspicion that there truly is apnea. Then the final consequence is this daytime sleepiness. Patients that I always did snore, but now I've noticed I'm snoring more. And boy, when I wake up, I feel unrefreshed. Now, whenever I have lunch, I just feel I just cannot stay awake. I have to lay down and take that nap. So when you hear those daytime consequences, a pretty good sign it may be more than just snoring.
So in essence, the sleep apnea is not getting enough oxygen in, and that's what's causing you to wake up.
It's not even necessarily because some patients, their oxygen doesn't drop that much. It's just this body's response to the apnea that they wake up, and then when you fragment. So some patients are having this occur 40, 50, 60 times an hour. And you can imagine, you can actually see these, what we call hypnograms, where we see these interruptions in their sleep. And you see a normal patient that may be waking up every hour or two and awake for 5 minutes. These patients may be waking up every 30 seconds repeatedly all night long. And you can see them in the clinic, and you're like, how do you even feel like you even slept? And they'll say, sometimes they'll say they don't at all.
Well, I think we think of people who are overweight. That would definitely not be you. So tell us, what kind of person has sleep apnea? How many people have it?
Overall, it kind of depends on your definition. It's a higher rate in men versus women. And then I already mentioned that index number. Sometimes the researchers will say, well, if you only have 5 an hour or 10 an hour, but you have no symptoms, does that really meet criteria for apnea? So it depends whether you combine symptoms with it versus just the study that shows you have apnea. At least 10, if not 20% of the population of males, by and large, will have it. There's a big difference on the population you study, too. Like I said, if you study a random population, there's studies in Wisconsin that are already around 30 years old now, though, and they found a rate in the population there up to 10-15%, depending if it was males, females, and other criteria. It's, like I said, strongly related to BMI, so the prevalence of obstructive sleep apnea is going up every year as the BMI is going up.
So what's that been like for you? How'd you know you had it?
Well, I've snored for a long time. I'm one of those guys who can snore and bring the house down. And you've heard people sawing logs. I'd saw the house and maybe rattle the windows. And then my wife, I was taking a nap one day in a chair, and I'd always ask her, "Do you think I have sleep apnea?" She said, "Oh no, you don't." Then she takes this video of me, and I showed it to Damien, and I was just kind of laying here on the couch. I was so I had both the fits. People call it the fits, where you kind of have. It's like you just kind of you can't
You're
breathe,
gasping,
and
yes.
you wake up, and you go back to, and you wake up, you go back to sleep, and and I watched it. I was like, how long have I been doing this?
Well, and your wife is a very wise doctor.
She's a wise physician. Like, how
Right.
long have I been doing this? So I take the video. I go, damn it, I sent it to David.
And what did you say when you saw the video?
I said, yeah, you've got apnea.
So
That's
then what
pretty
was
obvious.
so were you were surprised? You were surprised by the video, finding out that you had this. So then how did
So he is a great example. Like I
Yeah.
said, 15 to 20% of patients have a completely normal BMI, but quite often in that situation, you start asking other family members. Yes, brother snored, everyone snored. It's kind of interesting what he mentioned about the severity of snoring, how loud it is. And for years, we really didn't know if that really mattered. And actually, we finally did studies that. So yes. So when you do hear that, out in the hall, 3 doors down, then that's even more likely than just a little bit of snoring occasionally in some nights.
Let's just say people didn't want me to fall asleep on an
Yes.
airplane.
Anytime
Oh no, you would
yes.
do it on an
Oh.
airplane.
Jet engine or you're snoring? Which is
Oh,
louder? I'm
no.
not sure.
I've had about half a dozen patients in the hotel room, and the person next door in the hotel room called the front desk to check on the patient because they thought something was happening in the room.
Because they were
It's bad.
so
It's
loud.
bad.
Because they were so loud, yes.
And I remember the first night, so I can't get comfortable with CPAP. I'm like, you've got to be freaking kidding me. Because I put that thing on, I was like, holy cow, I can sleep.
Yeah.
This is great.
So you noticed a difference.
Oh.
You got used to it, and you've been on it for how many years?
Oh, over
10
a decade.
years
It's
at
been
least,
10,
yeah.
12 years
And will you
also.
always need it?
I
And
assume,
unfortunately,
unless
his
he's gonna cure
situation,
me.
very likely, what you do have patients that, maybe lose 30, 40 pounds, they may come off CPAP.
Okay.
But an individual that's a normal BMI in his situation, it's very unlikely he would necessarily come off because there's not really risk factors within his control that he could reverse, to get rid of it.
Okay, so
When-
tell
when
us
I
about
went on
CPAP
this,
too.
I weighed 160 pounds. I'm 6'1" when I went on it. Now I weigh more now. You get older, put a little weight on, but it has. I think it didn't make a difference
would
whether I
likely be
weigh
the
less or
same
more.
thing.
Right?
Yeah, exactly. In his situation, there's just not risk factors that are modifiable, as we say, that he could get rid of.
So CPAP that's the go-to treatment?
Stands for continuous. It's CPAP, continuous positive airway pressure. And all it is, it's an air compressor attached to a hose. It's attached to a mask. Very simple. It's been around since the 1980s.
So that's you at night?
Well, it could have been, except he has more hair than I do.
Yeah. Okay, just checking.
There's several different models of masks. One covers your nose and mouth. One only covers your nose. Others are pillows, as we say, that fits in your nostril. Very simple. It's nothing. I explain it to patients. It's kind of an air splint for the airway. It keeps your throat from collapsing. It uses air pressure. There's not oxygen. There's no medications involved. The original one was actually a vacuum sweeper turned backwards. So instead of sucking air, it actually blew the air out. And you pressurize it to a certain setting, gets rid of the apnea, gets rid of all the breath holding, gets rid of the snoring. Works great for those that can tolerate. In reality, about 2/3 of patients end up using it past the 6-month mark. But there's lots of other kind of relevant factors in that situation. You love the patient like Dr. Stites that walks back, the next day, and I never will sleep without this again. But then there are patients. That's what we've really struggled in the sleep field for years now. How can we pick those patients that are going to struggle and not do well versus the one that will never sleep a night without it? And to this day, we still can't quite figure out, why patients, do so well with it and the next patient struggles with it.
But I think
Here's a couple of stories. First of all, if I don't wear it, I have to get up and pee 5 times a night, which we
Yes.
know, right? Because people, your heart doesn't like it, your brain doesn't like it, and your kidneys don't like it, and my oxygen level dropped into the 60s, which is really severely low, and so my body was really unhappy. So there's this really positive reinforcement for me that comes every now and then. I'll fall asleep early, I'll lay down in bed, I don't put it on, and then I forget to put it on all night, and I wake up the next morning, I'm like, oh no, it's gonna be a bad day.
It was like the back in bed, the old days.
It's like you didn't sleep. It's just like, okay, that was dumb.
Well, Dr. Stevens, I think you had done an interview before, and it was about how this was like a game changer. Because what were the options before this?
There were essentially no options. The patients, you recommended losing weight, which we all know rarely, if ever, occurs. The old original treatment from back in the 70s and 80s, what we call a tracheostomy. You
the
literally cut a
trach,
hole
yeah.
in the neck, and they had a tube in the neck, and during the day they would put a cap over it. At night they would open it, because basically what a tracheostomy does is it bypasses the upper airway. So it's a plastic tube that you insert into the trachea through the neck, and they would uncap it, leave it open at night, and that was really the only effective therapy that we actually had until we developed Cpap therapy.
Wow. Okay, so let's talk about this Cpap recall, because I would imagine it's affecting lots of people.
It's a huge mess, yes. There's some of the publications said there may be 3 to 4 million machines. The quick story is there's 2 major manufacturers in the United States Outside the U.S., there are a few handful of others, and since this has all occurred, some of those other manufacturers have kind of landed in the United States market. But by and large, there's 2 manufacturers. ResMed was the one that is not recalled. So for any patients listening, any individuals, if you have a ResMed machine, it is not on the recall, so no reason to panic, no necessarily any reason to do anything different. Phillips Respironics is the manufacturer that was recalled. It's been almost 6 months now that this first occurred. What's happening is it's not even a filter to filter the air. There's a plug inside the machine, and it was actually placed there just to decrease the decibel level of the machine. Whenever they first started coming out with Cpap, one of the complaints was the bed partner was, by and large, most bed partners were happy there's no snoring, but there were a handful that would say, well, now you've got this machine that's making this hum, this noise, and then that bothers me, wakes me up. So there was a big race to try to see who could get the machine with the lowest decibel level. And that's when this started being placed in the machine. It's been around for decades now, but what they've realized in the Phillips Respironics machine over years, it seems that this will break down. There's a couple different things that occur. There's a gas that may be emitted from the plug that may have harmful effects. There's microparticles, as they say, that they can measure and may come through the mask, through the hose, and the patient may inhale it. Unfortunately, we have very little details on how common this is, how dangerous this is, what the health consequences may be, which are the risk factors. One specific risk factor they did mention, a lot of patients have bought these cleaning machines. So Clean is one. There's a couple other on the market now. Those machines, they say, may accelerate the breakdown of this plug because they use ozone, and they think this plug may break down with ozone. We really don't know how important or relevant that may be. Basically, they're now suing each other because Phillips Respironics said it was their fault, and they said, it's not our fault, so we have no idea really how important that is. What we've told patients, if you use a cleaning machine, stop using that. Just clean it the standard way we talk about, soap, water, nothing more than that. For most patients, that's good enough. But if you are using a cleaning device, to stop using that because we just don't know if that's truly a risk factor or not.
Okay, we are getting so many questions for you. Yeah, jump in because I'm going to go through these.
Now the machines, though, do we have enough ResMed out there to
so that's right those? There. He hit on the nail on the head. We are first of all, ResMed, both machines were on back order because of the pandemic. As you can imagine, the production of both machines was already delayed. The same thing with chips, with car manufacturing, everything else, supply line, shipping. So both machines were already, on back order. Then you take essentially half the machines off the market. Then they even became more stresses the supply chain even more. So there are patients that are waiting to get replaced. All I tell patients, if you go to the website, you can tell pretty easily on the website if you have a recalled machine or not. If it is recalled, register the machine, because that's really, it's not even known that you're on a recalled machine until you go in, register the machine, put your serial number in, and then you're at least in the queue on the waiting list. And that's the way to really start the ball rolling. The unfortunate part is what I already mentioned is there's already a shortage. Now, Phillips Respironics has the new plug, to place in the machine, and they've started shipping those out, but it's going to require, it's something the patient can't do themselves or even the medical equipment company. It's going to probably be directly from Phillips Respironics to replace the filter. They have produced their new machine that supposedly does not have this same issue. ResMed, like I said before, has been trying to keep up, but they can't necessarily keep up. There's a couple other manufacturers that now are in the market. So we're doing our best to keep up, but it's a huge issue right now.
Yeah, a couple of quick things. So it may be associated with some respiratory issues, even cancer. There's some early reports about that.
Early stuff that says yes.
Yeah, hopefully
What really has happened is this gas they measured, they think that may have some harmful effects, but we just don't know how high the level is the patient inhales. Originally, I was kind of like, well, it probably is not that big of a deal. We probably would have picked up on it sooner and else. But when you really think about it, if someone's sleeping 6, 7, 8 hours a night and inhaling this, and they've done this 5, 10 years, could it actually have a health consequence? We just don't know. It's too early to say.
So recalled. I had it for 10 years. Yep. Slept a lot of time on it, but so far no ill effect. Talk to a little bit. There are some surgical options for sleep apnea too, including like a pacer and things like that. Where do we stand with that?
So we've made progress compared to like the old days of a tracheostomy. Some patients can use an oral appliance, as we say. That's a mouthpiece that basically protrudes the lower jaw just a few millimeters. You know, when I talk to patients about it, and like, oh my God, it's going to, you know, pull my jaw. It's actually a small amount, and it's kind of interesting that that small of amount can help. But that is an option for patients that have mild, maybe moderate sleep apnea. Unfortunately, patients that have the more severe, it's probably not going to be effective. There's another procedure where we cut the roof of the mouth, open the back of the throat, shrink the tongue. So there's several surgical procedures that we've done for decades now. We originally thought they were fairly effective. They're not nearly as effective as we thought, but the newest procedure we do now is a nerve stimulator. And as Dr. Stites said, it's basically kind of a pacemaker for the tongue. And it's under the clavicle, runs a wire up to your neck to the nerve that controls the tongue motion. Not all patients are candidates for this either. Typically, if you have a higher BMI, you would not be a candidate. But as long as your BMI is only mildly elevated, as long as your apnea is mild to moderate to, we can do severe apnea in some patients. And we have to do a couple other tests where we actually literally have a scope in your airway while you're sleeping, and we look at the collapse. So there's certain patterns of collapse, but we've done over 300 now at KU of what it's called Inspire, or hypoglossal nerve stimulator therapy. And we place it, we let it rest for a month. It's an outpatient procedure. Patients come back, we turn it on after a month, and then we adjust the voltage to get rid of the snoring, to get rid of the apnea. And that has been shown to be very effective in a lot of patients.
I've not done that. Although you saw I could probably be a candidate, but I haven't done it because the CPAP machine works so darn well.
Exactly.
And, you know, just to say one more thing, those machines now are so quiet
compared to
that,
what we used
yeah,
to.
and this, some of them are
And
small.
small.
The portable ones are about the size
big ones
of,
that
they're
whenever
about
I
like
first
that.
when I first started doing it, it was a suitcase
Yeah.
that basically had no humidifier. There's been several changes that we made. Like I said, the original ones, the original mask were uncomfortable, but we've made a lot of progress on both the machine, both the humidification and the mask.
There's one called the Dream Station.
Yeah, baby.
Baby.
Okay, so I need to know, do you guys have to get back to work? Because we have a bunch of questions that I really want to get to Dr. Stevens.
No, I don't. I have a...
Okay, so I just want to
9
already
o'clock.
know we're going to get to those. But I'm going to start with Dr. Shoemaker because I don't want you to think you got that 8 hours of beauty sleep for nothing. Okay? So
And a
Isaac
bug-bye.
wants to know, because of so many asymptomatic infections, do you think that the antiviral pill from Pfizer will be a game changer regarding the course of the pandemic? He's concerned that the media is setting us up for disappointment on that front.
So I would agree with that. I mean, I think the oral antivirals are going to be just another arrow in the quiver. But, you know, we talked about this the other day, and he was speaking about the Pfizer one. The Merck one's about 30% effective in preventing hospitalizations. Right now, we think the preliminary data is the Pfizer is about 90%, but you have to take it with a booster called ritonavir. There'll be a lot of drug-drug interactions. And if you look at the study on the Pfizer pill, they had to start within 3 days of onset of symptoms. So we don't know what's going to happen for those patients who present 5, 7, or 10 days out. Still, the most effective thing in preventing hospitalizations and deaths is vaccination. So, yeah, I mean, I think the pills are going to be something to help us for those patients who cannot get the monoclonal antibody, who get symptomatic disease if they can get in quick enough to get it, but still vaccination is the key.
And just to say, I think the government's even setting us up a little bit to try and get to those, especially the Pfizer pill. The recommendations coming out of the White House yesterday were to pay for in-home testing. That's an interesting twist. Why are we going to pay for in-home testing? I think it's in order to get people into early therapy. I think that's going to go in conjunction with the Pfizer thing. And what we've watched is what the federal government's done historically is that you can kind of know where they're headed because they do a series of moves to get you set up for it. And I think they're starting to set us up for I think those two things probably go together.
Yeah, no, I agree with that. And one of the big challenges for some areas, I have a colleague at the University of Michigan system, and they're being overwhelmed right now. And they are trying to give as much monoclonal antibody as they can. But he said logistically there are just more patients than they can get through their system. So I think oral antivirals would be a substitute to help in those situations for the lower risk patients.
You say Michigan is the highest per capita in the country right now. Remember they had a huge outbreak early in the pandemic, and now they've got another major outbreak still driven by Delta at this point.
Mm-hmm. Okay, so Lori wants to know, can you make up sleep on the weekends, and should you be taking naps? Please say yes, please say yes.
That's what I do. Come on now. Don't let us down,
We
Damien.
love our naps.
I have no issue at all with naps as long as that patient is not then complaining, I wake up at 3 in the morning and can't go to sleep for an hour. It probably does not matter to a large degree when you get your sleep. You know, you mentioned yourself, you know, that and when you were doing the early morning hours, you'd have to sleep before, sleep afterwards. The problem with a lot of shift work is you look at their total sleep, it starts getting, you know, cut back because, hey, I need to go to bed by, you know, 6 p.m. because I got to be at work by 10 p.m., get a couple hours before. Well, then they stay up an hour later. So that's the most common thing is you start carving off this time before, carving up, I got to get up 30 minutes sooner. But as long as you get that sleep, it probably does not matter when you get to sleep, by and
Yes, we
large.
can nap.
Yes.
Nap away, my
But,
friend.
like I said, the
But
problem
I don't
is,
na-
it
I do
depends
have that
what-
problem.
it
If I
depends.
nap an hour and a half, I can't go to sleep. If I
See,
nap for
that's
30 minutes
exactly-
to 40 minutes, I'm fine.
So that patient that's napping, but then they're in my office because they're waking up at 3 in the morning and they're
Right.
awake for an hour in the middle of the night, and you start getting that history and they're taking a nap, then you've got
Okay.
to kind of, we call that sleep restriction whenever you're doing that.
So if you're napping a
situation.
lot, maybe make note of when and why you're
When
napping.
and why you're napping.
Well,
That's
can I just say,
exactly
the other thing I think we have to be careful with in America. So many people want a device to put them to sleep, or a
Yes.
drug to put them
A
to
drug
sleep.
to put them
And
to
the
sleep.
first thing you have to do is stop having caffeine
Ooh.
after about 11 or 12 in the morning. The folks are, I can't go to sleep. Well, when's your last caffeine? 6 or 7 o'clock. I had some with dinner. I'm like, well, you see, I can't help you get to sleep until you do the right thing.
Okay.
And you
the
have
other
to
big
stop
the
doing
other
that.
big part of this is alcohol and sleep, and that's
Yep.
probably a part of a lot of what we're seeing in the pandemic. You know, the rates of drinking and
Yeah.
the rates of alcohol, even admissions for alcoholic disease, and that's one of the most common things. It's actually alcohol is actually not a bad sleeping pill because that first 3 or 4 hours you fall asleep, and I will see a patient a month that they start drinking literally to help them sleep. The problem is
You
after
wake
3 or
up.
4 hours you've metabolized
Yes.
that. You wake up at 1 in the morning, 2 in the morning, and guess what? The rest of the night for the 3 or 4 hours you're tossing, you're turning, you
Your
sleep
brain
horribly.
is going
Your
and
brain is
swirling.
going.
Your brain
and
We've
that's-
all been there.
It's a squash.
It
It's a
is.
squash.
Yes.
Hey.
I
So
don't tell
don't
patients.
drink too much and don't take so much doggone caffeine. It's not, you know.
You're taking all the vices away.
Yeah, pretty much.
Dr. Seitz, I've got 3 special guests here to see you. Can we bring them in really quick, please?
I don't know who's the special guest. Let's see
Bring
who's
them
out there.
in.
I can't wait to see.
Usher
what this
them
is.
in. Come on in.
Oh
Somebody
boy.
forgot to unlock the studio.
Okay, come on in.
Awesome.
We've got our, so it's
Oh.
Cannon and Sunny
Hey there.
and Dominic are coming in to
Sup,
high five
Sonny?
you because they got their second shots.
Yeah.
Come
Come
around.
over here, guys. Well done. I
Sonny,
love
you
it.
wanna go over
Well
here?
done. Sonny
Come
says
on,
well
come
done.
Come-
Well done, brother. Well done, guys.
All right.
Thank you.
Kiddos.
This
Oh,
is
Dr.
the
Stites.
best.
Dr.
Yeah, go ahead and
Stites.
get right up in there.
This is my husband, Tony.
Tony.
You're just meeting all the family today.
Your whole it's the family
It's
affair
the
day
family
here.
show. Here, Sonny, just go stand by Stites.
All right, there you go.
All right,
What's up,
how'd it
Joe?
go, guys?
Let's do it.
Dad got you taken care of. Cannon, you're good. Mom, he did
Wait a
good.
minute, no, wait. You can't get over there by yourself. Get
Oh.
in
Get
the
over-
pit. No, this young man right here.
Get over
Stand
here.
Here's your mama.
Dominic.
Come on there. Come on.
He's what?
Okay.
He's got his
Oh, you can keep him on.
Well, he
You're
does have a
fine.
lollipop.
He's got
There
a
you
sucker.
go.
He's good. Okay, we got them shots down. Okay, good. All right, yes, big family affair.
It is.
And shots are in. Okay, so that's it. We
You
just
guys
wanted
feel
you
okay?
to.
They're done.
You didn't fall over? Did your arm fall off after the
Dr.
shot?
Seitz, this means she gets to go to Vegas. Remember?
Ooh. Wait a minute. Who were you taking to Vegas? I remember we had this conversation.
I get to go to Disneyland.
Disneyland and Vegas.
And where's Cannon going? You're going to Disneyland too, right?
Yes.
Awesome. Yeah, weren't you going to invite me to go?
Dominic, you can't talk
No.
unless you're over on camera.
Yeah.
Really?
Can't see
Come
you.
here.
No one
Come
can
here,
see
Cannon.
us.
Come over here.
Come here.
Get over there by sis.
Dude. Hey,
There
you
we
know
go.
what? Your sister likes you. What's this about?
Were there a
My
bunch of other
daughter would
kids
not
up
have
there
been
getting
that
shots?
awesome. Yeah,
I
awesome.
don't know. I
Not
didn't see
okay.
any. Yeah.
You didn't see any?
Did
Okay.
your arm
Yeah,
fall
it was
off?
pretty quiet.
Oh, I don't know.
Is it still attached? Let me see.
You feel it?
Everybody did good?
Oh, it did fall off. Oh my God, what are we gonna do about that?
Awesome.
We'll put it back on. We'll glue it. There's some glue back in the back. We'll put your arm back on.
All right, kids. All right, now you got to go to school. Sorry.
Fun
Sorry.
is over.
The,
Thank
the
you.
party is over. This is it. Now go learn something.
No, no,
Hey,
no.
Oh,
Dude,
yeah. Oh, yeah.
Where's my lollipop?
Go get one from.
Do I get one too?
No,
Oh.
from Alexis.
Just bump it.
You have to go get it from.
Hey, hey, hey.
You got to go get a shot. To
Don't
get
leave
one,
me
I think he
hang.
said.
Come on now.
No.
There you go.
You
No?
get it from Alexis.
Oh, you get it from Alexis.
Can I just ask, does the
All right, guys.
bling help you get the
Wait,
shot?
it's-
All right,
You
bye,
got it on the bling.
guys. Thanks, Dad, for
Bye.
doing the duty, doing the deed.
Nice to meet you. Hey, she's got a lot of bling. Is that
She
what
does
you
have
were
the
like?
bling. Bye,
Is that
poodle.
when you were a kid?
Bye, baby. Go. Oh, yeah, right. Yeah, she's stealing my jewelry.
Did
Bye,
you
guys. Thanks.
Did you have a lot of bling? when you grew up?
I didn't. I'm not a blinger. I'm not. But
She's
is.
a blinger.
She is a
Yeah,
blinger.
Okay.
Okay, so we're back
Emmy
on track
award
again.
winning. We forgot to say Emmy award winning.
Right? I know. So she deserves the bling. Okay, now we are back to our questions. I'm sorry, we just we had to surprise you with the
We had a little-
vaccinated,
we had
more
a cool
vaccinated
moment.
people in our lives.
And just to say, their arms have not fallen off. That's good.
Exactly, right? But now they have to go back. Okay, so here is the question. Oh, Maggie had a ResMed machine, and because of using the So Clean machine, ResMed says it will cost me $335 to repair my machine. My doc was surprised to hear the MesRed machine is also having problems. Do you know anything about any of this?
No, as far as what we've been told, there is no issue with the ResMed machine.
But isn't
So-
that the other part? Stop using some of these cleaning.
Yeah,
soap
there's
and
no-
water work just
That's it.
fine.
We did soap and water for years, but someone saw a chance to sell another machine. I think it was William Shatner was the So Clean guy.
Was he?
I think he was
Oh,
the guy
come
that-
on, Captain.
he
Let's
was the
do
guy
it.
hawking
Live
the-
There you
long
go,
and prosper.
see?
He's kind of
And like
emphasizing the prosper.
Oh, yeah. But like I said, now it's an all-out. Everyone's trying to throw each other under the bus of why it really is occurring. But as far as what I've heard, but if I still had a ResMed, I would not be using the So Clean either, because there's at least a chance that's the extra factor that's causing this breakdown of this, because they do have a similar plug within that machine also, which has not been reported yet.
Linda wants to know, does sleep position matter with sleep apnea?
Yes.
Okay.
About 15-20% of patients that have obstructive sleep apnea, they only have it on their back. Now, you can sometimes get a hint. Obviously, their bed partner. Okay, when's the snoring? Is it on their back, on their side, all night long? Is there a difference? And when you hear this story, well, they almost never snore on their side, and it's only when they're on their back, and they don't notice the apnea, and we do a study. If we do a sleep study that has a body position monitor in it, then we can actually answer that question. There are a handful of devices we test that doesn't have a body position monitor, so you don't really know that. And the reason that's relevant, if you are one of those, like I said, somewhere between 10 and 20% of patients, sometimes what we call positional therapy, a device that doesn't allow you to sleep on your back, would be an option. And I have maybe about 10% of my patients, I use that option because that is a way to avoid the mask, the machine, and that's what we call positional apnea, where it basically either only occurs on your back or the vast majority of the apnea. You may have a few on your side, and you'll see these patients. It's 40 times an hour on their back, and it's 1 or 2 on their side, so trying to keep them off their back may be an option.
How do you sleep, Dr. Stites?
On a
Well, if
CPAP.
I
On
had
your
my
back.
CPAP
Is that
on
you
my
have to
back.
sleep on your back?
Because
There's
if
no
I'm
choice.
on
That is
my-
the thing, though. If you're on the CPAP machine, you can sleep on your back
Yeah.
on your side, and it does allow you.
And
And
if
there
I'm
are
not-
some patients that fail this positional therapy that we try.
Okay.
They sleep on their back. They try this device. There's 3 or 4 that we try to keep them on. One's a cummerbund that has balloons in the back, and some will try that, and they are just miserable because they just are like.
I tried
determined
the
to
whole
sleep on
tennis
their
ball in the back thing, doesn't mean good. And my wife is just like, get on your side.
Yeah.
And if I don't have my CPAP
What'd you say,
on.
tennis ball? What'd you say?
One of the devices is a tennis ball. We actually literally have a tennis ball.
Yeah,
we
so
put
you
in a
can't
t-shirt,
turn back
so you
over.
can't turn on
I
your
just
back.
shove like a pillow under because I
Yeah.
don't like to be able to. I don't
Yeah.
like my
Do you
shoulder
need a
beat
sleep study?
Huh?
Do you need a sleep
I
study?
did do a sleep study once when I was doing that crazy morning
Yeah.
thing, and
Yeah.
you know,
can't
I
tell
had no
anything like
problems.
that.
You know
there
this. I
you
have
go.
no problems.
Okay.
Okay, so Isaac wants to know, how is it that some people can sleep through intense storms while others are jolted awake? She feels this is relevant here in Kansas and Missouri.
Yes, it is.
Was there a storm?
It's relevant. Actually,
slept through it, my friend.
that's an interesting question, because this is even probably relevant when we talk about everything from their zip code, how you sleep. You talk about areas that there's gunshots, there's a police siren, there's a fire, an ambulance going on all night, and there's this even socioeconomic effect of sleep and sleep quality. When you think about that and the sleep disruptors all night, and we call this environmental sleep disorder, when you have this noise, the decibel level, they will go and measure decibel level in houses in different settings, because there's even a difference in sleep in different ethnic groups in different zip codes, and that's part of what that is probably related to. As far as that specific, why someone wakes up and I don't and they do, that's something we just don't entirely understand. That's what we call the arousal threshold, and some people will wake up whenever they hear a key put in their front door, and other patients, you literally, about the only thing you can kind of consistently say about that arousal threshold for kids is much higher. That's whenever that kid, you can literally, pull them and sit them up out of bed, and they still go back to sleep when they're 12, 13 years old. And almost everybody, as we age, they have a lower arousal threshold, meaning a quieter noise, any trigger they're much more sensitive to triggers that wake them up as we age.
I wear earplugs every night.
I wear earplugs too.
Do you?
So my wife used to accuse me of not hearing the kids
Yes.
cry at night.
And some
And
people.
she always did. Really, I should have just said, honey, arousal index.
That's
Exactly. You have a
Oh, I don't know if that sounds
And what
right.
yours probably was,
It doesn't
and
sound
what
good.
truly yours was probably related to is patients that are kind of sleep deprived. They will quite often not wake up because they are so tired, and in between the apneic episodes, they're tired. They're so can't wake up because they're interrupted so much that quite often that's what's actually occurring.
Yeah, I've been wearing earplugs for like 12 years. Do you wear them even if there's no noise? I just have to have it.
yeah.
I have to have
I
it just like
just-
fill my head.
I just sleep better because any noise at all, because like you
Wakes
said,
you.
that noise, that I would wake up and hear anything. So that's why I wear 'em most nights.
All right, Dr. Shoemaker, we're coming for you soon to find out what your weird sleep habits are. I just have to ask you to get you. What do you just sleep
well,
like a baby?
No, I don't. I'm afraid if my wife's watching this, she's probably scheduling me a sleep study right
I
now.
bet. I bet.
I'm looking at his oral and his jawline. I'm just guessing he has it. What do you think?
Yeah.
There's a chance.
Maybe I'll call you,
We'll
Damien.
make an
I'll
appointment
schedule
in
an
clinic,
appointment.
yes.
Yeah.
Well, and it is. Here's the thing. Here's one thing you can all say about this. The more we look for it, the more we find it. It truly that is what we find. The more we look for it, because we've had this kind of idea. It's even in med school. We used to have sleep was not taught anything about sleep in med school, and that's been one of the big things. The American Academy of Sleep Medicine, all these other sleep societies, is we've kind of ignored this thing we're doing basically a third of our life, right? If it's 8 hours out of a 24-hour day, we've not learned about it in school. We've not taught it in med school and residency any of this time. So it's definitely one of those things that's on the radar more than it used to be.
Well, thinking about medical education, you think about the restrictions they put in place, just like they did for truckers. They have for
They started doing it for
residents and fellows,
and
which,
hours.
as we went through training, it was a badge of honor to work
Oh,
48
yeah.
hours straight. But is it really smart or safe
is
for
it smart? Yep. Patient
the
safety,
patients or for your
education, of
drive
your
home,
own. Exactly.
Yeah.
I know of
That's
two
changed over
residents.
the years, you're
oh
saying?
yeah,
Oh,
it's been
yeah.
a
Good.
huge change.
Yeah, and for the positive.
But not when you were in med school.
Oh no, like you said, that was whenever you worked all
Look,
night. And
When I was in medical school residency, there wasn't this work limit stuff.
No.
We worked 120 hours a week.
You would
easy.
drive home, and then you would not remember
I
driving
know.
home.
Well,
I
yeah,
know.
a lot of people actually did have car accidents driving home.
I know of
especially
two
college
residents
stuff.
that had an accident
Yeah.
driving home after their shift.
Yeah, I mean, we were on every other night, and and the complaint was the night you were off, you missed all the good cases. So really, you should have been there every night. But routinely, I had 6 months of every other night call as a resident.
That's
so.
rough. That's rough. Not about no badge of honor with
Yeah,
that.
it
Okay.
really isn't.
White noise.
No.
Trish wants to know: do you suggest white noise? I love the white noise, especially for the kiddos.
So yes, white noise can be very effective. It's basically the patient or individual's preference. It's kind of interesting because I already mentioned the reason they started putting this foam filter plug within the machine was to decrease the decibel level, but it turns out that many of my patients, it's the machine itself functions as a white noise, and they kind of get used to that little, hum, and that can be helpful for them. So yes, white noise machines. I have patients that have the ocean sound, the rain sound. If it's beneficial
effective.
for them, then they should do it.
Okay. Joanne wants to know: are you okay on time? I got
We
a few more
probably got
questions.
just one more, two more. I'm going to have to answer a page here.
Okay, that's fine. Joanne wants to know: my sleeping habits changed during menopause. Hardly getting any sleep now. What can I do to help?
Huge thing.
it?
There's two major transitions in females' life, males to some degree, but it's women even more, females more. When they have children, the sleep deprivation, the disruption, the sleep quality, every stage looked at it goes down. And then the second point is during menopause. Unfortunately, there's not a real good fix for it. We don't necessarily like to use, quote, sleeping pills, sleeping aids, because sometimes I'll do that if it's a short transition, because sometimes it's right around the menopause and 6 months, 12 months later it's better. I have a handful of patients that stay on hormone replacement just because the sleep part is so bad, the sweats at night are so bad, and that is the two kind of major life transition in females that we see pretty consistently.
What about the beds that move up and down? That was the question someone had.
That,
Did those help with
the,
sleep
the
apnea?
one thing for elevating the head of bed with mild apnea can help. It's almost never effective alone. What I do have a lot of patients that may have to have a nasal surgery, some other surgery. They can't wear their CPAP or some other issue. They have a bad cold. They can't breathe through the nose. So what I do tell them during those times, those few days, those weeks, elevate the head of the bed. And then quite often it's not quite as severe at that time. But outside of that, elevating the head of the bed is not a huge benefit from an apnea standpoint. It can be a benefit from a comfort standpoint. So if a patient's more comfortable, then yes, I would say to do that also.
I wish you could just come back tomorrow. I'm going to effort that because we have so many good questions. I don't know what to do with them. I know you guys got to get to your patients, so I'll get to some final thoughts.
Sure.
I'll let you get
I can
us
come
started,
back
Dr.
sometime.
Okay, tomorrow.
We'll have Dr. Stites come back with a CPAP machine.
There you
I don't know
go.
when let's figure
People
it
always
out.
want to
Let's
know what
schedule it.
happens and what your life is like behind the scenes. So to envision you
Pretty
on your
boring,
back.
actually. Watch
I'll
it
get his
start
wife to
up.
take a video tonight
I
while he's
would,
asleep. and we'll bring it.
I would love that. Just Dr. Stevens, what do you want us all to know just about getting better sleep and taking better care of ourselves?
Like you just said, it's taking care of ourselves. I do have to say that some patients are just watching the media. They become fixated on it, and sometimes it's time to turn it off. Take a break from all this, focus on yourself, get good exercise. I think a lot of patients are sitting in and not getting out as much. Unfortunately, now we're getting into the winter, so that's going to even be harder to do. But eat healthy, exercise. Shut it off whenever you can, and focus on allowing yourself that time to get sleep, basically.
Such great info today. Thanks so much. Well, it was nice to kind of take a little bit of a break from COVID and talk about sleep, something that affects all of us. So, Dr. Shoemaker, thanks so much for being here with us.
You bet.
We appreciate it. Just what are your words of advice? What do you want us to head on to now?
Not to go back in the future or the past, but yesterday was World AIDS Day, so make sure you get tested. I know you don't want me to talk about COVID, but you got to get vaccinated for COVID. But don't forget your flu shots too. Mm-hmm. We're getting into the influenza season, and we don't want to be having to try to differentiate between COVID-19 and influenza. So make sure you get all your vaccines and your HIV test.
Thank you. Thank you so much for
And
that
a quick
reminder.
follow-up on that, I was on Lawrence call yesterday with University. I think they've had 10 cases of influenza this week. So last year we got a free pass with influenza. We're not going to get a free pass this year. And so it's going to be out there. Make sure you take care of yourself. Remember that the rules of infection, prevention, and control travel with you and keep you safe wherever you go. And the more we follow the rules, the better off we are. So wash your hands, wear your mask, get yourself vaccinated, keep your distance. It really will keep us safe throughout this holiday season. Don't turn Omicron into oh my gosh. Mm-hmm. Don't get into a frenzy about it. It's going to be okay. I think the early indications look okay, especially if you're vaccinated. Cross our fingers, but I think we can find our way to safety and a good holiday season if we just remember to follow the rules. And hats off to those young kids who just came through here.
Yes.
Their arms didn't fall off. They did a great job. They were happy. They got both vaccines. That's awesome.
They got both vaccines. It's a sucker.
They are, and a sucker.
You
Life
can't
is good.
get better than
And
that.
they're going to Disneyland, and they're not taking me, evidently. I thought I got to go when they were here last time.
I thought
I've been
you were
booted.
going to Vegas.
Vegas, I've been booted. You heard us. Do I get to
Oh,
go?
I don't
Nope.
know. Maybe, I don't know.
Okay.
Maybe you can get back.
I
I'll
don't have
talk
enough-
to him. I'll try to get you in.
I don't have enough bling.
I'll try to
I didn't even get a sucker when I got my shots.
You what?
Yeah.
I didn't even get a sucker.
What?
I didn't either.
Or a sticker? Did you get a
No.
sticker?
I didn't get a sticker.
No
No
sticker.
sucker. Okay.
I got a Band-Aid, though.
You guys were
I did get a
slighted.
Band-Aid.
Band-Aid.
Gosh, all right. I don't know. You guys, maybe I just know people here, I guess. Maybe.
You
Yes,
do.
you
You're,
got the
you're just
connections, I
cooler.
think.
Some of us may not be cool.
I appreciate all three of you today. Thanks so much for this. I know we had so many great questions coming in. I promise I will hold on to these and we will get to them. Remember also to snap pics of those kids getting their brave shots. We appreciate those. Showing their guns off, showing their Band-Aids, their suckers, all that. We're just really proud of all these kids getting their vaccines. So send those in to us on Facebook Messenger or to the Medical News Network at kumc.edu. You can email them to me at jlevel also, and we'll show them right here on air. Thanks for being with us today. Don't forget you can catch our show anytime on Facebook and YouTube. And tomorrow we're going to get to those follow-up questions. It's Follow-Up Friday. We're going to talk about the Omicron variant now that it's been confirmed here in the U.S. And the Community Blood Center is reaching out and needs all of our help. How you can give the best gift ever this season, and it won't cost you a thing. That's tomorrow. Have a great day. We'll see you at 8 tomorrow.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.